My name is Megan Westling, and I want to welcome you all to this sponsored program titled Expanding Services to Support Sustainable Comprehensive Medication Management. A couple of housekeeping items before I introduce our speakers for today's program. We will be recording the didactic portion of this program, and we will be posting it to the Ambulatory Care PRN YouTube channel following conclusion of the program today. We will also be using breakout rooms for the roundtable portion with the support of a facilitator for each room. We kindly ask that when these portions of the program occur, we please turn on your videos and/or be able to actively participate in the discussion. We really hope that this program and the structure of the program serves as a good opportunity for you to engage and learn from your peers across the country. Without further ado, it is my pleasure to introduce Drs. Cindy King and Bradley Winter. Dr. King is an ambulatory care pharmacy specialist at Metro Health System and an associate professor at Northeast Ohio Medical University College of Pharmacy. She's certified ambulatory care pharmacist. She currently is in a shared faculty role and practices in internal and family medicine, specializing in the treatment and management of chronic diseases. She also serves as a residency program director for Metro Health's PGY2 ambulatory care residency and previously served as RPD of their PGY1 program for 6 years. While at Metro Health for the past 7.5 years, she has worked to initiate ambulatory care services and has provided data-driven research to help expand ambulatory care pharmacist team from 3 clinic-based pharmacists to 8. We also have Dr. Winter, who is an ambulatory care pharmacist board certified in ambulatory care. He currently works as the manager of the Intermountain Health ambulatory primary care pharmacy team in Utah, where he leads a team of over 20 clinical pharmacists. He received his Doctor of Pharmacy degree from the University of Utah, then completed a general residency program in Oregon before specializing in ambulatory care and primary care with Intermountain Health in Salt Lake City, Utah. He's since stayed with Intermountain Health to start clinical pharmacist services in a family medicine clinic where he manages chronic diseases such as diabetes, hypertension, and also introduced clinical pharmacy support to their chronic pain clinic. While there, Brad has precepted pharmacy students, PGY1 and PGY2 residents, and is also adjunct faculty for the University of Utah College of Pharmacy. I want to thank Drs. King and Winter for being here to share your expertise. And with that, I will turn it over to you two to get us started.
All right, thank you, Megan. Appreciate the introduction and appreciate the opportunity to talk to everybody today. As mentioned, my name is Brad Winter. I'll get us started, and then Cindy and I will kind of go back and forth and just really focus on telling our story and see what elements we've learned along our journey that we can potentially share with you folks today. So you can go to the next slide, Cindy. Just briefly, we have objectives associated with this next hour and a half. Our hope is to focus on the kind of the steps that have helped us in our journey, such as creating standardized definitions of our services, improvements in data collection analysis, identification of beneficial metrics, and then as well just comparing and contrasting the different elements to help us grow and sustain our services. Go to the next slide. We have a brief outline. You probably saw this as you were registering, but we're going to talk for a little bit, and we'll break out into smaller groups for open discussion, and we'll debrief, and then Cindy and I'll talk for a little bit, and then we'll repeat over the next hour and a half. So go ahead to the next slide. Brief introduction. Hopefully this is not new to most on the call, but the name of the game that we're really focused on today is comprehensive medication management. The idea has been around for a long time. The essential components are that it's a patient-centered approach to optimizing medication use and improving patient health outcomes. We're very passionate that this is a role that is defined by a clinical pharmacist in collaboration with others on the health team. I know in my own system, we've relented that, yes, there are wonderful individuals that can dose medicines, that can titrate a medicine outside of clinical pharmacists, but comprehensive medication management is unique to our profession and our training and offers a lot of benefits. With that, I'm going to pass it over to Cindy.
There we go. Thank you so much. So like Brad said, we were really kind of going to tell our story, but also include some information from other programs that are really excelling at CMM. One of the things that we really noticed when we started kind of talking with each other and figuring out what all we were going to talk with you guys about today is that Brad and I have kind of experienced similar journeys, although he and his group out in Utah are a little bit further along than where I'm at my current health system. But a few of the things that we really wanted to focus on is that CMM can be successfully implemented and expanded in a variety of settings. Community pharmacies, ambulatory care clinics, whether that's in a specialty clinic, primary care, FQHC, urgent care, emergency room, correctional institutions, as well as VAs. Also, it can be seen within healthcare plans or managed care. And so depending upon the setting that you're in and you find yourself focusing on CMM, this will ultimately drive some of your focus, your metrics, as well as your initiatives. So when we were really discussing, we found that, everybody has to start somewhere. And in that initial hiring of the first few people in ambulatory care doing the CMMs, you kind of have some initial hurdles that you get through and that you are able to ultimately justify your first few expansions. And so these first few expansions tend to be smaller, maybe adding 1 or 2 FTEs. And then you kind of go through some more growing pains and adjustments as you work to further define and expand your services. And then you start to have more of these large scale expansions and escalations of services. And so this was something that Brad and I thought was really unique since we're kind of at different parts along this timeline, that hopefully as we share our stories as well as other literature that's out there, it kind of meets each of you where you're at and explores what the next steps are that you might be experiencing as you look to sustainably grow your CMM services. So just a little bit more about me and the health system that I work at. I work at Metro Health System. We are a public hospital, a safety net hospital in Northeast Ohio. Before I started at Metro Health in the spring of 2016, they really didn't have ambulatory care services. The very beginning of 2016, they had hired their very first pharmacist in ambulatory care, specifically in heart failure. But really, other than that, they were very inpatient focused. At that time, HealthSpan, which was formerly Kaiser Permanente, was leaving Northeast Ohio, and Metro Health was purchasing their former buildings. And at that time, we had 2 PGY1 residents. Myself, along with 2 anechoic pharmacists and 2 other clinic-based primary care pharmacists, were hired on in the spring of 2016. And this is really where we started to see that initial establishment of CMM, kind of that initial implementation of services and trying to figure out, how are we going to justify these positions? At this time, we also increased from 2 residents, PGY1 residents, to 4, with 2 of those being more focused in ambulatory care when it came to their electives. If we fast forward to present day, we have continued to expand, and I would say in the last year or 2, it's been a much more rapid expansion. But we now have 3 pharmacists who do anticoagulation and population health management, mostly focus on diabetes for those population health pharmacists. But they also work with 3 registered nurses and 1 administrative assistant. So they have much more of kind of their own built-in team. We have 7 primary care-based pharmacists, 2 ambulatory pharmacists that are in specialty clinics with cardiology and pulmonary. And then from our specialty pharmacy, we have 5 of those that are clinic-based, and we have added 2 PGY2 ambulatory care residents as well. So I just wanted to kind of break down some of these major breakthroughs and the timeline. Since ambulatory care services at my health system are still relatively new, like I said, we have been expanding, and I feel like in the last couple of years, we've been expanding more quickly. And I felt like it would be beneficial to discuss how we've gotten to where we are. And this we really found by a few main kind of categories. So we found consistency was a really big thing. Even though we're within an academic medical center, Metro Health has over 30 medical offices. And so each of the ambulatory pharmacists are in a different medical office. So we found that consistency was really important when it came to documentation, the types of services, the knowledge level of the individuals. Also, it was important to share our data. So quality metrics, our reports, research, all of those things helped to create the data that we were sharing. Which then ultimately led to our outcomes. And then finally, telling our story. To me, telling our story is really important, not only internally within the pharmacy department, but externally, making sure that the key stakeholders outside of pharmacy were aware of all of the things that we were doing. And then also presenting outside of the health system, whether that be posters, presentations, publications, awards, those sorts of things. So I'm just going to kind of discuss year by year how we accomplished the expansion that we've had so far. So like I mentioned, 2016 was really just where we were initiating services in Ohio. The collaborative practice agreements had made substantial changes in 2016. And we were also able to bill, we mainly focus on the hospital, we're a hospital-based outpatient clinic, so we are more so doing incident to billing. In 2017, 2018, we did 2 different diabetes studies to demonstrate the impact of pharmacist management, not only on diabetes, but the comorbid conditions as well. We were also recognized as a best practice award winner through the OSHP organization. In 2018, there was also expansion where our anticoagulation pharmacists ended up taking over the management of all anticoagulation patients throughout the entire health system versus just a few selected locations. And then in 2019, Ohio made it so that pharmacists were recognized as providers, which was very exciting as well. Not necessarily something unique to my health system, but we felt like it, has helped with our expansion. In 2020 was when we first received approval for the PGY2 in ambulatory care, and we completed a geriatric study looking at more comprehensive medication management recommendations to an interdisciplinary team. 2021, we started looking at our panel sizes. So our pharmacists were getting more referrals than we were able to manage. And so this study really helped to justify future positions and really show the need of, how many pharmacists per patient lives were really needed in order to provide the level of service that we were currently doing. We also, this is where we started to add more of our pharmacist FTEs that you can see over this past 3 years. In 2022, we looked at our population health group and their diabetes management. We added our second PGY2 and started creating more of those specialized positions. And then this most recent year, we finished up our e-consult study. So providers across the health system are able to prescribe or send e-consults, so electronic questions on specific patients that we're then able to respond to, which has helped with medication management on a more global standpoint, aside from the ones that we're actively, seeing on our clinic schedules. And then we nearly doubled the size of our primary care team. And at the end of this year, we'll be adding an ambulatory manager. So with all of those expansions and kind of breakthroughs, it really came down to a few things. One, making it sustainable. So we were able to justify our sustainability of these services through quality metrics, such as, getting more patients with an A1C less than 9% or, having a higher blood pressure level. Also through our billing and decreasing overall costs. So decreasing hospitalizations, emergency room visits, also freeing up our primary care provider schedules to actually see more of those acute patients, which then also helps to decrease those unnecessary emergency room visits. And then as part of that, making sure that we were getting this data, that we were showing this sustainability to the correct people. So making sure that we were establishing those key stakeholders within our health system and other advocates that would help to, encourage the growth of our profession and of our services within the health system. One of the things that we did at Metro when we first started is any provider within the health system could refer their patient to us for CMM. They did not have to be at the clinic where the pharmacist is located. So this has really been one of the big things that has helped us to continue to grow, because we have multiple clinic sites saying, where's our pharmacist? Like, we want a pharmacist here in the clinic with us. But it also has helped to make sure that as we roll out services, that there is a little bit more equitable access to care across the health system versus just in certain locations. So that has also been helpful to our patients as well as the providers. And then with our workflow, making sure that we have access to the data that we need. So sometimes, especially early on, we didn't necessarily have reports built, or we weren't able to pull the information that we wanted on the report. So that's where research projects can be really helpful, whether you partner with residents or students or do it on your own, can be very helpful early on in the process. And then once you get more established and can work with your IS team, actually having reports that you can run on a regular basis, whether it's created by informatics or that you are able to self-generate. But we feel like these things are incredibly important in order to demonstrate the impact that your service is having on your health system, your patients, your providers, and ultimately, providing this unique service, like what Brad said, that is, specific to pharmacy. So with that, I'm going to turn it over to Brad to talk about his practice site.
Thank you so much, Cindy. Appreciate it. So as mentioned, I work for Intermountain Health. You can see our map has grown a lot, but the circle around the state of Utah is where most of the journey I'm going to talk about was focused. Intermountain Health is a large health system that's been primarily focused in the Utah area, a couple of sites up in Idaho and down into some other states. But over the last 2 to 3 years, we've had some mergers and acquisitions, as I'm sure is not unfamiliar from others out there in the healthcare world. And our overall organization has grown quite a bit. And I'll talk a little bit about some of that in the end. But for now, I'm going to focus really on the journey that we've had here in the original kind of footprint of Intermountain Health. And similar to Megan, we kind of wanted to just tell our story, make it personal. So when I started with Intermountain Health as a PGY2 resident many years ago in 2015, our ambulatory care program was pretty small, honestly. Prior to me starting, it started with an anticoagulation clinic about 20 years ago in our largest hospital, as well as a few other outpatient clinics that used pharmacists to help train medical residents in our larger academic centers. Right before I started, there was a primary care pilot where they hired 2 pharmacists to be embedded into 2 of our over 100 primary care sites and focus on medication disease state management like hypertension, as well as transitions of care. From that meager pilot, we got a residency approved, as well as a few other pharmacists as we started to show some disease state outcome benefit. When I started in 2015, as I mentioned, our team was a little smaller. It was 6 pharmacists spread out in primary care and 2 ambulatory care residents. Since that time, we have currently, again, just in the circle, 24 ambulatory care pharmacists in primary care. We have small but growing, this is kind of our next area of growth, set of ambulatory care pharmacists in outpatient specialty clinics, including rheumatology, pulmonology, chronic pain, and endocrinology, as well as some other ologies on the way in the coming months and years. Our anticoagulation centers have 3 major centers, but in those 3 major centers, they've consolidated all of the vitamin K antagonist management into those centers using both in-person as well as virtual means to cover our footprint. We continue to have our residency And then kind of the more recent addition has been a team of ambulatory care pharmacists and technicians that exist in a remote sense. We call them our telehealth pharmacy, AmCare pharmacy team. And those pharmacists and technicians help to expand our reach beyond where a lot of our pharmacists that are embedded in primary care just can't get to. They do a lot of population health focused work, as well as supporting clinics that are either between pharmacists or don't have full time access to an embedded pharmacist, as well providing a lot of support in the area of medication assistance and access. We have a dedicated team of technicians that help with navigating the many, barriers patients face in getting access to medications, including patient assistance programs and things like that. As I mentioned, we've merged with other healthcare systems. And so our ambulatory care team has not quite, but almost doubled if you include the whole system. And we're currently in the work of integrating and working to standardize across those teams. Go ahead and change the slide, Cindy. Thank you. So I don't want to go too in depth with our whole journey. You can see our timeline there. What this is meant to signify is that every AmCare practice, whether it's a large system or a small system, is a multi-year journey. There will be lots of barriers along the way, but also a lot of key breakthroughs. I'm going to focus on just two of the many that we've had over the years. If you look at the top line, you'll see things like a study or a project, and as Cindy mentioned, leveraging our ability to do outcomes-based research either with residents or local academics institutions, or quality improvement upon our on our own team has been key. But you can go to the next slide. What I really want to focus on first is kind of going back to that, what is CMM? We found that we would present mountains of data at the beginning. See, look at all these wonderful studies that show that pharmacists can have a benefit when you aim them at a problem, right? Hey, pharmacists can help in lowering A1Cs. Pharmacists can help in achieving guideline-directed medication therapy, and et cetera. But when we looked at the data and when our administration looked at the data, they saw a very heterogeneous grouping of things to do. They're like, okay, so you guys know a lot about things and you can do a lot of things, but like, what are you selling? What do you do? And that's where our group really honed in on it and aligned with the principles of comprehensive medication management to help us define what it is we do. Now, this statement on the slide should feel very similar. It's halfway stolen from CMM, but this is what we wrote as our very, very brief, single, short paragraph, or very long sentence, poorly structured, I'm sure, statement, our elevator pitch. What is ambulatory care pharmacy for Intermountain? And so we focused on a few key elements. We said it's a clinical service provided by a pharmacist. Again, we had some corners where there was fantastic nurses working off of protocols, or our APP colleagues doing phenomenal management of disease states. And so we wanted to hone in on like what makes us special. We also wanted to emphasize we're in collaboration with, whether that's via collaborative practice agreements or just direct collaboration, we're on the team of other healthcare providers within our system. We wanted to differentiate from population health or managed care. We work with specific patients. We may have population health help guide us to the patients we need to see, but we work individually with those patients. The other thing we emphasize is that we're comprehensive. I may get a referral for insulin titration, but I'm looking at the whole patient, not just blood sugar equals how many units. I'm looking at the whole patient, their experiences with medicines in the healthcare system, their other conditions, and all that could pertain to that. And then we really focus in on the ways to optimize that medication therapy, right? We have our wheelhouse, and that's medicines, and we work in close conjunction with our other colleagues that have other skill sets. Go ahead and change slide, Cindy. Thank you. So once we really established what do you do, the next big piece of work was how do we do it? How do we do it in a way where we highlight what we do, where it's visible? Now, at Intermountain Health, we had a new opportunity about 8 years ago where we were shifting to a new EMR. And we saw that as a great time for us as a small but growing group of ambulatory care pharmacists to really hone in on what we do and how we do our work. Our previous EMR was honestly a very homegrown electronic system that was a glorified document system. It didn't have a lot of sophisticated tools. And so as we began work into our new EMR, we were like, great, show us how AmCare pharmacists work. And to be honest, it was a little bit of a letdown because I was the first pharmacist to be trained on our new EMR, and they sent me to inpatient pharmacist training. And I'm like, oh, I don't verify orders for the hospital. Oh, well, we'll send you to outpatient pharmacist training, which focused on outpatient dispensing tools. And I said, well, I don't dispense medicines. Okay, we'll send you to provider training. Sounds like you do more work like an outpatient provider. I said, great. I went to that training and said, yes, this is what I want. They're like, oh, well, those tools aren't built for a pharmacist, you silly man. And so we really had to build from the ground up and work very closely with a lot of folks, both in the pharmacy department and outside of the pharmacy department. One thing, you'll see a little splash there on my side. We utilized the CMM practice management self-assessment tool that hopefully many are aware of. If not, we can talk about it later. But there's this self-assessment tool that has various categories that essentially you get to answer where you're at on a scale of various things. And it helped us to identify best practices where we were limited and needed some more support, helped us aim some of our focus on what we needed to really build out in our system. And then from there, we really honed in on those workflow tools. We also really wanted to focus in on efficiency. So documentation workflows. We built out templates, and we went through, I can't say how many versions of various data collection methods. And it's a continued process. Even to this day, we have a team, kind of a subgroup on our team. We call them the technology team of our pharmacists, and they work in conjunction with our informatics colleagues. And we're constantly looking at, if we were to build out a new type of encounter in our system that would better allow us to perform work or track work that we're doing. What about how we're communicating with our provider colleagues outside of Intermountain? Are there tools that others have developed that we can utilize? So we're constantly doing this work of how can we best use the tools at our disposal? I'll be completely honest, it's a lot of work. It's very hard to do this by yourself on the side while you're in a busy clinic. So I know that everyone has, their limitations on the practice that they're supporting, but trying to carve out a little bit of time to have this focus can really help. As I mentioned, we have a work group of several pharmacists that share the load. They meet once a month to talk about where we're at and what we can do. And it's not a huge lift for any one of them anymore, but we continue to get that work going. So those are the two main things I wanted to share from our journey as just little pearls to consider. And I believe it's time for our first breakout session, if I'm not mistaken. And hopefully somebody can confirm me. Everyone's on mute.
It looks like we're there, and I do have breakout room assignments in place. So if there's no additional instructions for the audience members, I will go ahead and open up the rooms.
Great, thanks. All righty, I will go ahead and get us started again, if that's all right. So hopefully everybody had a great opportunity to get to know some of the folks on the webinar today and have some initial discussions. So if our leads from the different breakout rooms could maybe talk about if there were any specific like data-driven metrics that any of the participants were really focusing on, or if there was something really stand out in your group that you'd like to share with everybody.
I can start. I'll share a few of the metrics. So there was some similarities as far as looking at diabetes metrics, hypertension, readmission rates, things like that as well. And one of our members also was looking at specifically percent of patients who have CKD and looking to see if they're following guideline-based therapy. So specifically looking at like if they're on an SGLT2 or statins and things like that as well. So it's quite a variety of different quality metrics. And some are developing new services, or they're have their own business, and so they definitely look at the patient satisfaction, patient care piece of things on that side of things as well. And then in addition to that, we had some of our members in our group were talking to about their colleagues, like the physicians, APPs, things like that. Their provider satisfaction was also another piece that helped to determine whether or not they were able to expand their clinical pharmacy services.
Wonderful. Thank you so much, Jennifer.
I can comment on behalf of our group. So in our group, most of our folks seemed like they were more disease state based as far as how CMM practice went for them. And so accordingly, some of the metrics that were mentioned in our room were A1C, proportion of days covered for the patient's entire medication history, which I thought was interesting, statin coverage, but then there was also some more unique things that some of these pharmacists were mentioning that they got to be responsible for, like rates of colorectal cancer screening, mammograms, things like that, from the standpoint of when they were treating these more as like annual wellness visits, that type of thing.
Thank you, Clayton.
I can go next. So in my group, we actually had a variety of different backgrounds, from people students to PGY1 residents to pharmacists with many, many years of experience, and some in managerial roles. One thing that we saw was kind of similar among them as far as the quality measures was the HADIS scores, was something that was brought up by a few of the members in my group. And then another thing that was in common among them was the billing. Those that were using billing was the incident to billing across the board. So those were kind of what we discussed in our group.
Thanks, Estella.
For our group, a lot of the same information as far as metrics and disease state driven metrics. We did also mention one of the groups is looking at how they're offloading work for physicians by having pharmacists involved in the management, in addition to looking at the appropriateness of regimen to we've had some experience with people looking at heart failure regimens as well, and having a pharmacist dedicated to that. And then for billing, we also discussed that a bit, where we had different experiences with both the incident to billing and the facility fee billing.
Great, thank you, Megan.
And I'll speak up for our group. A lot of the same stuff, but one thing that I thought was really cool to highlight was finding ways to identify care gap closure, even if it's along the way with disease state or comprehensive. So vaccinations, preventative exams, monitoring labs for kidney disease and things like that. So tracking an effect that pharmacists have on improving on closing care gaps.
Absolutely. Thanks, Brad. I think there's one more group, if I counted correctly. Otherwise, we'll just dive right in. So you guys mentioned a lot of the things that we had come up with as well, which we're going to dive into in more detail in the second half of the session today. So one of the things that I found really interesting when just investigating the literature a little bit more out there regarding CMM is this focus on the quadruple aim of CMM, which focuses on clinician experience, cost, patient experience, and then those clinical quality metrics. So what I think was really awesome, from our initial set of discussions is, at least between all of the groups, at least somebody hit on each one of these items. And I think it really is key when you're looking to expand services and really get the buy-in to support those, is to really make sure that we're hitting on each of these. So as we move forward, I wanted to spend a little bit of time just focusing on where the opportunities are and how we can demonstrate this quadruple aim. So it is important, just, as I'm sure many of us know, over 50% of Americans have at least one chronic condition, and non-adherence of medications results in over $100 billion per year of excess hospitalizations. And then, as many of us know, 50 to 75% of patients are non-adherent to their medications. I recently, within the last year, had to start taking preventative therapy for migraines, and they started me on a BID dosing of a medication, which I was horrible at. I very quickly had to go back to my neurologist and be like, look, we got to do something different. So, as pharmacists, being able to provide either medication recommendations or under collaborative practice agreements, being able to adjust, medications to be able to help with this is hugely impactful to patients. So as I was looking at, how do we go about addressing this quadruple aim, and, what are other folks out there doing? Because there's so many wonderful examples of all of the things that pharmacists are doing. I came across a few examples of how certain health systems have really worked to make CMM sustainable. There were two examples in this reference that I've included. I decided to focus on the Fairview pharmacy system. The other one was through the VA, which was also able to provide some really great examples. But Fairview Pharmacy has 23 CMM pharmacists, which totaled 18 FTEs, and they have those pharmacists spread over 30 locations. And they were able to, take that quadruple aim and ultimately end up focusing on patient outcomes, improving access to care, improving the quality of care. They were able to demonstrate a decrease in costs through cost avoidance, as well as cost savings, decrease of health expenditures, as well as improvement of patient satisfaction. And a few of their numbers that I wanted to share were just so impactful. And I think, again, it tells that whole story. So they were able to decrease health expenditures by $3,000 per patient. They were able to demonstrate an estimated cost avoidance by the pharmacists of nearly $2 million annually. They had significant improvements in their HEDIS criteria, both for hypertension and lipid management, a decrease in diabetes hospitalization costs, improvements in medication appropriateness, as well as adherence. And, on more of those humanistic factors, 93% of surveyed patients felt like the pharmacist CMM services were extremely or very helpful, and 89% of them would refer to friends or family. So I think this really just helps to bring home the fact that, what we're doing through CMM services is not just hitting on one targeted item. Yes, I may be seeing a patient for diabetes, but maybe I'm also helping to make sure that they get scheduled to see their primary care doctor because they were lost to follow-up, or getting them in for their optometry visit, or, helping with their kidney screening. We're really looking at the whole patient and really trying to make sure that we're improving the care that they're receiving and hitting on all of these different items. One of the newer focuses within CMM is a focus on including social determinants of health. So social determinants of health, if you're not familiar with that terminology, would be looking at food or housing insecurities, transportation challenges, just to name a few. And so here's several examples from multiple different states across the United States where they have been combining CMM and social determinants of health to improve patient metrics. And so actually, when we look at social determinants of health, Healthy People 2030 has actually integrated social determinants of health into the pharmacy workflow. And so there is grants available specifically to those of you who are in FQHCs. It's through BD, Helping Build Healthy Communities. And they provide grants to help to incorporate CMM and social determinants of health initiatives that you can apply to each year. So, depending upon where you are located, that may be a resource that's available, but something else to kind of think about when you're working to justify, positions. Social determinants of health has been a really big focus and may help to give you that push that you need to expand sustainably. And with that, I will turn it back over to Brad.
All right, thank you, Cindy. Yeah, some amazing examples out there and some amazing points shared from the group in our session. And so we'll try to make sure we've got plenty of time for the next round. This is kind of a slide that discusses a lot of what we've been talking about. And I just wanted to outline a couple of just the techniques or ways to get started. If you're like a lot of us, like me at some points, feeling overwhelmed with, gosh, what do I do now? I would say that one of the best things you can do is look at existing tools and workflows. We did a lot of investigation in our own system where we even said, hey, can I spend some time at the various EMR trainings for other caregivers in our system? Nurses in various roles like care management, providers in various roles like primary care and specialty care. And so we spent some time trying to get to know what are other people using within our own ecosystem of tools, as well as those outside of our system. Here in Utah, we've got another pretty big group of AmCare pharmacists with the University of Utah Health. And so we partnered with them, and we actually ran both of our teams through that practice management evaluation tool that I mentioned earlier. And we kind of compared notes and said, how are we doing as a state? So I think there's a lot of things you can investigate within your system. We found recently that there was this really fun tool that providers have been using that helps them identify gaps in their care. And so we're utilizing that population health tool and applying it to our pharmacist populations. So we make sure that we're covering gaps as well as those areas of pockets of patients that potentially we could benefit. Making key partnerships, again, within your pharmacy departments, within your information systems departments, medical leadership, EMR companies. I've tried to get myself very well acquainted with the various representatives that don't work for our system, but work for the EMR company that we use, as well as outside organizations, ACCP, for example, other practices in your area. There's so much out there to glean from others. Sometimes I feel like when I do that, I'm more focused on what I'm jealous of. But there is a lot that we can learn and apply. And then lastly, as we've been talking about, identifying those metrics and then really digging into how can I actually get to this? I know some people have mentioned good old Excel spreadsheet tracking, and sometimes that's where it starts, right? But really trying to dig deeper into that. There's a few people that mentioned provider satisfaction and patient satisfaction. We've been working with our department that does provider level post visit surveys. And we've been building out a survey that can be sent out to patients that see a pharmacist in person in the very same manner, but with questions that maybe relate a little more to our service. And that's something that, yes, we're not on the highest priority of their list because it doesn't affect billing practices. But we've gotten our nose in there, and after months of work with them, we're pretty soon to start launching a regular patient satisfaction survey related to our pharmacist work. And it's pretty fun. You can go to the next slide, please. So what does this look like? I'll give you just a little flavor of some of what we build out in our system. This is going to look different in various areas. But I was telling my breakout group a little bit about this. At Intermountain, we worked really hard to try to develop a real-time scorecard, where essentially every time an AmCare pharmacist interacts with a patient, whether it's an in-person in-depth visit, a quick phone call visit, a video visit, or even electronic message back and forth with providers or with patients, we've built into our system a way to track those things. And so we have this real-time scorecard where at any point our leadership can say, how many patients has ambulatory care helped for a given time? And we can pull it right up. And that's been a very, very powerful tool in telling our story to leadership above us. Eventually, we took that data and we said, okay, let's create an objective or coded way of tracking certain data elements that you really can't get from just your note. Notes are really good and important and great ways to communicate, but they're essentially just empty bags of texts in our system, and we can't get to a lot of data in them. So we created this little pop-up form that pops up, and we've done timing studies. It takes less than 2 minutes to fill out per patient. And so we feel like it's been a useful tool. And the pharmacist, after they've completed all of their notes, all of their orders, it pops up and they say, okay, click, 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 done. And some of those clicks include things like, what are the various medication therapy problems that were addressed today in my interaction with the patient? From that, you can see that I just pulled this just the other day, just so I can say like, okay, 2022. We had 24 spots. We didn't have them all filled throughout the year. So about 20 to 22 pharmacists, depending on the moment, throughout 2022 in primary care. We were able to tell our leadership, yep, we helped patients 34,000 times in last year. That was spread over 14,000 unique patients. From this actually scorecard, we can drill down to individual patient data. So we have a big well of information that residents love to dip into to do various quality improvement and research studies. We did find that 82% of our work was telehealth. Now we're in the clinic, we're in person, but we find that a lot of patients really engage, especially post-pandemic, virtually. And so this is a great way to tell our story of what are your pharmacists doing? Now, what's coming of it? Well, we've been tracking medication therapy problems, and we categorize them very basically with the PQA, or Pharmacy Quality Alliance, scoring pharmacy therapy, medication therapy problems. And from those 34,000 visits, we had 52,000 MTPs, and we categorize in various ways. Compared to other literature, I'll just comment that we're very adherence heavy, because our work of our pharmacy technicians, that we have a team that helps with that. I mentioned that gets dumped into the same bucket of data when we're looking at our ambulatory pharmacy services. But we can see like, hey, here's all these things. Now, what we've been doing the last year or so is we've been taking primary literature that shows return on investment, that shows pharmacoeconomics data, anything that ties MTPs or CMM related outcomes to a dollar value. We've been plugging that into a calculator that we've added to our scorecard that essentially estimates from this work, hey, when we identify a certain problem, there's literature that shows that on average that can save X amount of dollars in avoided costs, from preventing admissions, preventing acute care visits to EDs or to the clinic, et cetera. And so from that, we can say, hey, this money does not represent all we do, but based on what we've done and on literature, we estimate that our pharmacists are potentially avoiding $10 million of excessive healthcare spending last year. And that number has really spoken to our leadership. Now, we are working with our population health partners and our value-based care partners to track over time, because a lot of these savings are years in the making, to validate some of these numbers. But it really, really helps to conceptualize, yes, I'm doing something now that'll benefit later, but here's what the data or primary literature suggests could be that payout as we move forward. And this has been a really, really powerful discussion point over the last couple of years that we've been using this. So next slide, Cindy. And I think that brings us 2 minutes late to our next breakout session. So very, very general points as we go into the next breakout session. We really encourage you all to consider, do you have an explicit answer to the question, what do you do? And can you replicate it at every site? Data is king. Finding data is so important. We always really try to align anytime I present a bar graph or whatever, I didn't have time today, with a real life story. So we make sure that our administrators know these are real people that we're really helping. Building partnerships outside of your comfort zone can be really important. I put a note here, the more we bridge outside, the more we have opportunity to help others and build a pharmacy group that becomes indispensable. That administration could not even imagine living without their pharmacists. And then lastly, financial alignment. Whether you have a value-based system, a billing system, if you're looking at savings, if risk mitigation is a good one. We've gotten FTEs before because there were some sentinel events and we're like, how do we prevent this? We don't want this to happen. Well, pharmacy could be a part of that answer. And so finding those niches, those ways to align with the incentives of your organization is very important. So I'll be done now so we can jump to our next breakout session. All right. Thanks, everybody. And just as we conclude, I just want to say I'm inspired by the growth of AmCare all over the country. This is a really exciting time. But yeah, I'd love to hear from various representatives from each of our groups as we grappled with some of these questions.
I'd be glad to start for group 4. Some of the things that we talked about were kind of moving beyond information that's trapped in notes, pushing for payers to automatically capture data for pharmacists as they do for other providers in some cases, integration of like IT, pharmacists with IT in order to like integrate the EHR into dashboards and scorecards, things like that were what our conversation focused on.
Thank you. And I will say, as we go through other groups, I think the bottom of the hour was the time we had blocked off. Is that right, Megan? So fully appreciate if people need to drop off. I can hang on for another few minutes if there's comments or questions as we move along, but really appreciate the opportunity. I don't know if you need to say anything, Megan, before we move on to the next comments.
No, I'll follow your lead. The end will be at 2:30, but those that want to hang around, we can keep it open for a few more minutes.
Okay. All right, other group comments.
Yeah, I'll speak for our group. They had some great feedback as far as very similar to what Clayton was saying, but having a partner in biostats to help be able to generate those reports and maybe potentially having a pharmacy analyst to work with IT reports that are easily accessible. One of our members had said that they have actually incorporated dummy billing codes because it might be a self-insured employer where they can't use other types of codes. So they created their own in order to help generate reports more focused on specific disease states or interventions in general of what they were working on. And then another comment was that the data should be something that is clickable in order to help make it as quick as possible to collect that data and then make it where you can generate reports off of that as well.
Yes, coded data is very important.
For group 3, ours was pretty quick. We were very focused on coded data. Some people were still stuck with Excel sheets, but I think our biggest opportunity or need would be that tech support. So having somebody to actually follow through with our meetings with us and have certain things built, it can take a while to get that stuff set up. So these are all great ideas, so we appreciate it.
And I'll keep it short and simple. The main thing from my group was to have a pharmacist-friendly electronic medical record will certainly be very helpful.
I'll speak for our group a little bit. Very similar discussions. I really liked how, as we talked about the various tools in our EMRs, we had a number of us admit which EMR we used, and it's interesting how it seems like many areas have built similar workflows within the same EMR, but the core product doesn't have a lot of to offer. And so reinventing the wheel. So kind of going back to that, reach out to folks and learn from others that have been through it, as well as acknowledging different ways to support expansion, either in the cost avoidance or even revenue capture, as we partner with maybe outpatient pharmacy services and dispensing pharmacy services, utilizing programs like 340B and other programs like that. So we talked through some of those things. I think we should have at least one or two other groups. Or maybe that was all of them. I didn't count. All right. I think we can move to just general questions. If anybody has any last, burning questions or answers that Cindy or I can engage with if she's still on the call. Love to hear it. Otherwise, thank you so much for joining.
Hey, Brad. My name is Shannon Finks. I just want to make a complimentary comment. I'm on the Board of Regents right now, and I just wanted to let you know how proud we are of the work of the AmCare PRN. This was fantastic, and it's a great forum to share strategies and to learn one another. And I think I shared this with my group. One of the things that we as a board are looking at is our strategic plan for the next several years to come. And one of the gaps that we're trying to address in engaging clinical pharmacy colleagues is the area of IT. And that came up over and over and over again, and how we as an AmCare group, but also as just an organization, need to embrace our IT pharmacists. They are so involved in clinical pharmacy, and yet they may not have a professional home. And so if you have IT people out there at your institutions, let them know we care and we want to really engage them in our activities. And I want to thank everybody for your participation today. I'm going to take this back to the board and say, job well done. That AmCare group doing a good job.
Oh, thank you. I'll throw in an extra plug, and I know this is not comfortable for most of us that love seeing patients, even becoming an informatics pharmacist. There's lots of opportunity out there, and sometimes they are seeking help from people that are frontline. Something to consider, that a few of my colleagues have gone down that route. Awesome, thank you.